joined by Keith Summers of Health Corum, and I'm excited to have you as my guest, Keith. Welcome.
Thank you. Great to be here.
You're really looking for a value-based care evaluation, right? How much value is in the care?
We tend to say that our quality scores are really aimed at driving towards value. So someone with a high score is a good fit for a value-based arrangement, is what we've seen. So it's a broad view of quality. We think that it needs to encompass all those things. It can't just be what a HEDIS measurement might look at very narrowly. It needs to be across the board, right? Is this a provider that has a good combination of factors that make them the optimal choice for me to seek care with?
Okay. Patient experience scores, wait times,
So patient experience,
rescheduling, patient feedback.
that goes back to like the Yelp style score, which we don't do
You
that.
leave all of that. You leave all of that alone.
We don't touch that.
Too soft, too subjective.
There's a place for it. Sometimes our scores complement that. So you might see a patient satisfaction score alongside ours, but that's not
But
our.
it is subjective. You
It
have
is.
self-selection bias,
It is exactly,
right?
exactly. So
Participation rates typically 10 to 20%. So 80% plus of your patients you're never hearing from. So why are you hearing from the 10%?
exactly.
It's almost like the problem with democracy. Most people don't vote.
Yeah, exactly.
Okay, so you leave all that stuff alone. So what else are you measuring?
So our score, put that aside for a second, right? We also have other things in the data we can see that are, I think, really important to make the right decision. So one of those things is experience. We can see which providers are doing more of the CPT code or the procedure category that you're interested in. And you can match those two together and say, I want the highest score who has 20 or more instances of doing this specific surgery that I need to have done. Or you have someone who is treating the population that's more relevant to you, right? They're seeing older or younger patients or more males or females. So there's some of these other filters I think you can combine with the scoring that make it more relevant.
So you really should be the most popular man in America. Because if you think about it, any patient looking for treatment should call you first
I mean,
and say, Keith, who do you recommend?
I hate to say it, but my Blue Cross plan right now, they don't have this. And I go in there and I'm disappointed. I revert to Health Forum's dashboards to find a new PCP, like just happened recently.
I'm going to
Yeah.
call you after this podcast with a question.
Our, yeah, I mean, some of our investors have called us and said, "Hey, I'm looking to have this done. Can you tell me?" Because their carrier doesn't have this information. It's pretty insane when you think about it. So we're trying to get this in the hands of as many people as possible and kind of spread the good word and bring power to the decision makers because this is expected now. Like there's been, I think, consumerization of healthcare that's happened over the past 10 years and it's only moving in one direction. So we're hopefully going to be part of that solution.
Any interesting strategic partnerships for you?
There's a number of them. I think the biggest that we've
Apple Watch, MyChart, EMRs.
not as much on that side of things. I would say more categorically aligning our data with price transparency. And you've probably seen and you've had guests on that have talked about some of the regulation around transparency and pricing and what that means for payers and providers. So we've partnered with several of the leading price transparency organizations in the market. We work hand in hand with what we call our transparency hub as a throughput of all that data to serve it alongside our quality scoring. So kind of completing the picture with quality scores and price transparency to give that optimal experience for consumers.
It is interesting to think about the product on a price adjusted basis is really a paradigm shift for most people.
It is.
Right? It isn't in other industries. You think about cars and you're going to pay more for a better car, and that's understood. But to apply that level of thinking to healthcare providers is quite a shift.
It
I
is.
know I have a better orthopedic surgeon over there, but I'm going to pick the one who's not as good or because I don't want to incur that level of cost. I mean, we're obviously very sensitive to that in cash-based care, whether it's plastic surgery and cosmetics or whether it's dental or out-of-network care, pain out-of-network, things like chiropractors, PT. Anytime we come across cash and or out-of-network, we become incredibly price sensitive in seconds. But for most of us, I would say 80 to 90% of our care is insurance based. And so we just don't make the connection, even though it does ultimately drive our premiums. It just does it in a social cost format, right?
It's a classic
Tragedy
example.
of the commons.
It's a
So
classic.
let me ask you. Go ahead, Keith. Don't me interrupt.
Oh no, sorry. I was just gonna say, you're out to dinner and someone orders a drink, and you're gonna split the
Yeah.
bill anyways, right? So might as well order another round, and suddenly your bill doubles, and people just
Yeah, game theory. The last thing you want to do is order the least in a group environment at a restaurant.
exactly, exactly.
Yeah, it's perverse. So, given all the analysis that you've done across the country, what are the most interesting findings? If you were Malcolm Gladwell and you were writing a book about interesting discoveries in US healthcare, and I'm assuming you haven't had access to equivalent data in other countries, so the cross border comparison is not necessarily at your fingertips, but the cross state comparisons, cross city, cross zip code, cross region, north south, east west, blue red, racial, demographic, gender, whatever it is, assuming you have no sensitivities, political sensitivities whatsoever, and you just let the data do the talking. What have you discovered? And I have no idea what the answer is to that question, but I'm assuming you've discovered some things.
We've seen a lot of interesting trends in our work.
Are female doctors better than male doctors? Let me put you on the spot. Uh, are experienced doctors better than inexperienced doctors? Does age really matter? Is medicine better in the South than in the North, in the East and the West? Where is it more? I mean, now that you've got price transparency flowing through your fingertips, where
Yeah,
is it more cost effective? So, what are the big takeaways?
yeah. I'll take a shot at it. So,
How are we doing?
um, we're not doing well. And I think that's largely due to a very convoluted system that still does not surface the right information, despite the best efforts of us and many of our comrades that are out there trying to deliver really impactful solutions. That said,
Well, let me
yeah,
stop you there. How clean is the data that you're dealing with? I mean, you're looking at a lot of government data and large payer data. Do you process it well, or do you struggle with the cleanliness of it?
there's a science to it that not everyone can just deal with these files. Like they're a little bit unwieldy.
You're getting faxes.
No faxes, but there is a bit of cleanup to do. That said, it's once you get it going, and we're on this kind of like flywheel of processing each quarter and bringing in the new set and rolling out the next set of deliverables, it becomes a pretty well-oiled machine. So that's less of the concern. I mean, the price transparency side is interesting because that's come about recently, and that data is improving and getting cleaner. To that point, what we've been able to see is that price doesn't correlate.
You're like the Doge of healthcare.
To an extent, you could say that we're doing some of that good work. Yeah. Although we try to stay out of the media a little bit more than maybe
What
Doge.
have you discovered? What's going on?
So there's a discrepancy between price and quality. It doesn't correlate neatly, right? You just by knowing how you shop for things typically might think that the highest priced doctor or procedure might be the best one, and that's not the case at all. It's all over the map. So it's really important for stakeholders to consider
All over the map within a given zip code?
all over the map, just in
I
general.
mean, I would understand that healthcare in a very expensive city with a high cost of living is going to cost more than healthcare in a low cost of living environment,
Right.
right? Tier B town in Tennessee, not Nashville, in Tennessee versus Manhattan, right? Or Los Angeles. So that I would anticipate in terms of price. But you're saying even within the same city, there may be provider A charging twice as much as provider B, and provider B is providing better care.
Absolutely. I mean, a classic example is looking at like an inpatient surgery at a hospital versus something that's done at an ASC. And there's been lots of data that shows you have better outcomes if you're at an ASC, oftentimes. The hospital might be 3 times the cost. So there's tons of those examples out there. I think it's more about the climate within any given city or county, right? You can have negotiations that take place with a lot of leverage with certain providers, and then others they have equal leverage and they can get a better rate, and that's not going to show up on anyone's radar from a consumer perspective. So you'll see the pricing difference and you might make that jump. Hey, this is more expensive, it must be better.
Pricing in healthcare in the US has not, and in many countries, by the way, has nothing to do with demand.
Exactly. So that's one thing we've noticed. I think another
Everything to do with leverage.
exactly I think another, just geographically and kind of putting a little shade on like Boston and Northeast right now, but we thought that because it's such an innovative place from a healthcare perspective historically, that we would see a ton of traction here. And it's a no-brainer, right? You're going to get lots of people wanting to consume your data in the big healthcare cities. We've actually found the opposite, that oftentimes the Midwest, the South, they're kind of thirsty for innovation and they're willing to do things that are a little less proven than those that are in the major metros. So it was just kind of a unexpected result, I guess, of where these places have been historically and where they are on the maturity cycle as a healthcare system.
That is interesting. I think it lines up with another data point, which is aggregate spend. And so the South historically and today is spending less per capita on healthcare than the North.
Mm.
It's not universally true, but it's generally true. And even amongst northern states, there's wide variance. We were just going through this, the former head of CMMI and me, Liz Fowler, has now become a friend. No one spends more on healthcare per capita than New York, over $14,000. Boston wasn't that bad. I think it was around 10,000.
Mm.
No one spends less on healthcare per capita than I think Texas, which is something like $7,000 to $8,000 per capita. So basically, New York is spending 2 times per resident what Texas is spending. And you would think that that spend is a function of interest level, investment, R&D, quality of care. And I suspect that it's more a function of the opposite. Lack of interest, lack of efficiency, lack of solutions. I don't think that's an entirely fair statement because I do think there's a much heavier Medicaid component to New York than Texas. And Texas is trying to pretend that Medicaid doesn't even exist based on the numbers. So I think that drives a lot of cost as well as the social aspect, social responsibility, Medicaid coverage. And I think Medicaid funding, working with ACA as opposed to rejecting ACA. And the game is afoot, that those rules are changing now again. And we'll see how different states respond to new rules. But it is interesting. Different states react differently, just as you're saying, Keith, just in terms of wanting information. That's helpful.
Yeah. There's definitely there's an appetite to do more. I think if you're in an area where things are a little bit tighter and you have to find creative solutions and you have to innovate. So I'm looking back on it, it's not surprising, but that's definitely driven a lot of our growth as a company. I mean, our first health plan client was a mid-sized health plan in Wisconsin. Wisconsin's a very interesting state and a lot of competition there. So every part of the country is unique, and you have to really understand the local elements to, I think, do good work in the various.
So whether it's competition or tight budgets, it drives a thirst
Exactly.
for knowledge. I get that. So where are the best doctors? Where do they reside and practice? Which regions?
We don't have that viewpoint, I guess, just because our analysis is localized.
You're trying to be kind to everyone.
Well, I think that obviously there's going to be more providers in more populated areas. So, yes, maybe the best doctors are going to be in the very populated metros just because of the sheer numbers. But I don't think it's a catch all. And at least from our perspective, like the way we look at things is relative to your peers in a given geo and subspecialty, where do you fall? So it doesn't matter if you're performing a certain way relative to someone across the country. If from the patient side, they're only going to have access to you, right? It doesn't matter what the other guy is doing necessarily from a decision-making perspective.
Where are the best average doctors? Or where are the best doctors on average?
Loaded question. It doesn't really play out that way, to be honest, at least from the data we see.
What region punches above its weight? What region gets very good scores consistently for its providers because it has access to better schools? It is investing in physician well-being in ways that other states are not, whether it's state level interpretation of regulations, or whether it's approach to malpractice laws, or whether it's supporting investment in healthcare systems and infrastructure. Whatever it is, which state consistently seems to show up with a bucket load of very well-performing clinicians.
Kind
And
of
you
like,
scratch your head and going, why is that state seemingly doing so well? Low readmission rates, right?
yeah,
Low adverse events,
tough
risk
question.
adjusted.
I mean, I can't answer it directly just because, again, I don't have that data necessarily. But what I have observed from being at the various health plan state specific conferences over the past couple of years is that Texas does a lot of interesting things and I think seems to be on the right track. And the providers there are good. It's not necessarily like a hub for education, right? You don't think of parts of Texas necessarily as competing with like the New Yorks and Bostons and LAs of the world, but there's just a different mindset there, I think, and a mindset towards reducing waste. And it kind of follows some of the political lines, maybe trying to cut back on things that are unnecessary. So you end up seeing really great outcomes in those places at a better value, if that makes sense.
Yeah, I'm just going to look up percentage. Let's see if I can type of health systems. Let's see if ChatGPT fixed its issues this morning. Percentage of health systems in Texas that are for profit. So if the is it going to work? Yeah, it looks much better than this morning. Okay, 52% to 53% of hospitals in Texas are for profit. And to compare that to the rest of the country, it's typically 30% countrywide. I'm sure in some states it's much lower than 30%. So there's a heavy weighting of for profit hospitals in Texas. I imagine that has some impact on how they behave, for better and for worse.
I would expect so. I would expect so. Yeah. Because you're aligning incentives there, right? So it makes a lot more sense.
Okay. Any other key findings from your data?
What else?
What's the strangest finding you've come across? The one that stands out that you share at dinner parties? To win friends and influence people.
Yeah, right. We observed a lot of interesting things.
I'm surprised you didn't mention Maryland. I mean, Maryland, if you're dealing with pricing, right, has uniform pricing across the entire state. So I'm just surprised that you don't look at
Well,
that state and see very different results.
well, from maybe from a pure pricing perspective, but
Yeah.
that's not really like our main focus. Where we want to see the best mix, right? And we want to see not just the sticker price, but what does total cost of care mean?
But they've seemingly removed the issue of poor quality provider charging more than high quality provider.
Yeah, yeah, you're right to an extent. So dinner party questions. I've seen some interesting stuff. I mean, the COVID analysis I think was a cool one that we did internally because we saw suddenly the data changed, right? And then we also were able to compare that actually to when there was the whole changed healthcare data breach. Suddenly, again, the data changed. And so doing just those analyses of like how do people change behavior and then what does that mean downstream in terms of our visibility to data can make a big difference.
What happened during COVID or change that was particularly interesting?
Well, for COVID, as you would expect, things got delayed, and you would kind of expect that okay, once people are out and about again, they're just going to go and do what they should have been doing, and that wasn't the case. There was kind of like a long tail to the recovery. People that needed to have a surgery done didn't just do it right away. They maybe did it later on, if at all. So I think we were expecting more of a snapback after mandates were lifted and so forth, and that really wasn't observed.
What do you think that's about? I mean, I often wonder whether we're giving time for healing enough credit in medicine in America. Everyone gets their treatment now, and
Yes,
all of a sudden you can't get treatment, and 6 months go by, and you realize, maybe I didn't even need it.
there's a
Almost
balance.
like,
The balance there, right? Because
yeah,
on the one hand, yes, that might be the case for many people, and others maybe they had something chronic that they weren't treating, and they had an even worse outcome, and ended up becoming a greater drain on the system
yeah,
as a
acute
result.
needs remain. There's no shortage of them.
Exactly,
But it is interesting that it wasn't an immediate snapback.
it wasn't.
It does suggest that there's something strange out there going on that we haven't necessarily perfectly understood
Yeah,
about
there's
patients and care providers.
there was a shift in people's mindset for sure.
You would think mathematically that it would just be a build-up, and it wasn't. So very interesting. You
Yeah.
don't have an answer to that riddle quite yet.
Not yet.
Okay, we're gonna have to dig into that together, you and me.
We'll dissect
We'll
it.
write a white paper.
Yeah, exactly.
The snapback, where was it? All right, Keith, I want to thank you for your time today. I thought it was very enjoyable, and I'm sure our listeners will really appreciate your insights.
Yeah, likewise. Great conversation and really love the pod. So keep up the good work.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.